of the speaker committee. I wish to welcome everybody, and I have the pleasure of introducing our speaker today. This is Dr. Jaivir Rathore, a neurologist, and I'm going to tell you a little bit about him. He is the co-chairman of the Epilepsy Foundation of America, the Florida chapter, medical director, Falcon Advanced Neurology and Epilepsy Freedom Center. And if you notice on your tables, everybody should have a card as well with his information on it. He is triple board certified, American Board of Psychiatry and Neurology, neurology, epilepsy, and clinical neurophysiology. Former vice chairman and chief fellow, the Johns Hopkins Clinical Fellows Council, Baltimore, Maryland. In addition, he is an alumnus fellow from the Cleveland Clinic Epilepsy Center, Cleveland, Ohio, a member of the American Academy of Neurology and CME Committee, American Epilepsy Society, a member and reviewers panel Neurology, the official journal of the American Academy of Neurology, and also you may find him on NBC on The Doctor Is In. And all you have to do is Google that, put his name up, and that will come up. So I'm very honored to present our speaker today. Enjoy, everybody.
Good afternoon, ladies. I don't think the gentlemen's here today, but can you hear me? Okay, good. So my friends call me Jay, so you can call me Jay as well. So I'm a neurologist, I'm an epilepsy specialist, and as Diane mentioned, trained in Cleveland Clinic, Johns Hopkins, two of the top hospital centers in the country. I did my residency from University of Illinois, Chicago, and my med school from India, where I originally from. I came here after my fellowship and 1 year of being a faculty at Johns Hopkins Hospital in Baltimore. I was director of the epilepsy section at the Lakeland Regional Health in Lakeland, Florida, along with Watson Clinic. And then I have started my own medical center in Orlando, which is primarily for seizures and sleep. So, I come here with Tri-County Health 3 days a week. Tuesdays I'm in Summerfield, and Wednesdays and Thursdays in Wildwood. My practice, covers everything in neurology, so feel free to ask me if you have any questions, although I'm a seizure specialist. The only board certified seizure specialist north of Orlando to Gainesville and north of Tampa to Gainesville. And I'm co-chairman for the Epilepsy Foundation. We do a lot of charity work, educational activities, seizure first aids, and a lot of other activities. You can go to Epilepsy Foundation website to get more information. So today I was told to address primarily two topics, but I'll be happy to answer any questions related to neurology. It doesn't have to restrict to these two topics. So one was dizziness and stroke. So dizziness and stroke, these could be related, but they may not necessarily be related as well. Okay, let's talk about a little bit of dizziness. So dizziness can be of different types. It's a very generic, non-medical word, dizziness. Okay, you may feel dizzy for various reasons. Some of it could be lightheaded dizzy. So whenever patients tell me that they have dizziness, I ask them, okay, please describe it to me. What do you mean by dizzy? So is it lightheaded? When you suddenly get up, you feel lightheaded for a second or two, you hold on to something, you feel better. Or sometimes when you're laying flat and you sit up, suddenly you feel lightheaded. So that is one type, and of course, that could be due to reduced cerebral blood flow, cerebral perfusion. If you have less blood volume and you suddenly stand up, there's an autonomic system that works all the time to automatically adjust the gravitational pull of your blood pressure based on your position. Sometimes as you grow, older, as you age gracefully, that system takes a little longer to kick in. So that could be one possible reason, especially when 65 plus, that may be one possible reason. So we have to specify that what kind of dizziness do you get. Sometimes one of the possible reasons is polypharmacy. Okay, 65 plus, every doctor you go to for any reason, you get one pill or two. And that adds up. So when I see patients, there's a long list of medications. So always you have to look at that what possible medication out of these I can take them out or simplify their regimen, because many times it's polypharmacy that gives you a weird sense of dizziness without feeling lightheaded, okay? So that's one thing that you have to look for. Certain cardiac medications, they can drop your blood pressure. So you have to make sure, furosemides, beta blockers, they will lower your blood pressure. So you have to look for. When the patient comes in, you take their vitals, you see if the diastolic pressure is low, that would give you a hint that this could be because of low blood pressure, all right? So that's one thing. And you always should check their 3-position, laying flat, supine, sitting up, standing up, orthostatic vitals to see if there is any significant drop in their blood pressure. So the heart rate goes up. That will give you a clue into that. Heart rate goes up, it could be a POTS syndrome, or postural orthostatic and tachycardia syndrome, okay? There are certain medications we use, migraines or Northeras, those kind of medications can be used as well. One other common type of dizziness that you can see in geriatric population is room spinning dizziness. Patient will tell you that as soon as I sit up in my position, everything is whoa. They use this word actually as soon as they have this sensation that room spinning. And in my practice and practical life experience, it doesn't have to be that dramatic. Sometimes it is very subtle. So you may not get that kind of dizziness, room spinning dizziness, but that could be because of the otoliths in your inner ear, your crystals. So those crystals, which basically are moving around in those hair cells in the endolymph, as the aging happens, some of them are not that intact and they keep falling down, and they gives you intermittent. That's why the word benign positional paroxysmal vertigo. So vertigo word should be reserved for that kind of room spinning dizziness. If somebody has a history of trauma to the head, fall, hit to the head and stuff, that can again happen. Even in a younger age, they can have these vertigo, room spinning sensation, dizziness early in the ages, not necessarily have to be 65 plus. So that is another. Sometimes you will see the patients would come, even younger patients, and all across the spectrum, they would say, I feel a little unsteadiness or dizziness, but it's not room spinning, it is not, I don't know what it is. It doesn't really get worse when I suddenly stand up or something. I've tried all the Epilepsy maneuvers and I have vestibular rehab, everything is done. Sometimes I get little headaches, sometimes something like that. So you would not get a very great black and white picture of one particular of these that I've mentioned. So you always, when there is a headache associated with that, sometimes that may not be there as well. You have to think about basilar migraines, okay? Many people, and they will give you history of some form of migrainous features. They may have squiggly lines, kaleidoscopic views, may have a nausea associated with that, with the dizziness. So you have to really delve into details of that thing. Any family history, my sister had it, my mom had it, it's a little bit more common in females. So you have to suspect that that could be a basilar migraine. So migraine is a weird animal. It can do variety of symptoms, okay? Which could be just having little dizziness, okay? It could be, if it travels to the back of the head in the occipital area, it can give you blurry vision. It can give you blackout vision as well, which returns after some time. If it travels upward here, where the motor strip is, it can give you one-sided weakness along with dizziness, and that is very commonly confused with TIAs or strokes. Okay, so you have to be very careful with that. But again, you have to first go for TIAs and stroke rather than suspect a basilar migraine. That is a diagnosis of exclusion. So that's one form of dizziness that you have to. And one very commonly I see here in the villages since I started here in July is the cervical spondylosis. That you have arthritis. You have arthritis in your knees, somewhere here, there, also in the neck. So always look for the flexibility of the neck. Ask them to do complete side-to-side movements. Sometimes they have restricted neck range of motion. Sometimes they feel like little, achiness around their shoulders and the necks. Some tingling in the fingers here and there. So you have to suspect that thing. And then, if you check their Romberg sign, which basically you ask them to stand straight, put their feet together, close your eyes. Okay, if they do balance that kind of thing without visual input, that tells you that the dorsal fibers that goes in the back of the spinal cord are getting compromised there because of the tightness in the neck. It could be herniated discs, bulging discs. It could be thickening of the ligamental flavum, or it could be just a osteoarthritic changes. And some people have genetically narrow spinal canal, and as they grow older, some arthritic changes can have a little pressure on the spinal cord. And that will give you the dizzy spells, especially in bathroom or somewhere else when you're taking shower, when you close your eyes, you will feel very unsteady. Many of the falls happens in shower because of some of these reasons, not necessarily everybody is slipping on the floor. Because when the water falls, you close your eyes and then you lose your balance. So these are the potential causes that you have to look for, okay? So polypharmacy, benign positional vertigo, medication of polypharmacy, arthritic changes, and cervical spinal stenosis, the technical diagnostic term that we use for this thing, okay? And orthostatic hypotension that you have to look for. So these are the changes. Some other weird thing that can give you dizziness is seizures can give you dizziness. Okay, so the seizure activity happens, it doesn't do convulsions, and just makes you dizzy, confused, and dizzy, and it goes away. So anything that comes and goes quickly, you have to think about seizures. Okay, so seizure is one of the possible causes for dizzy episodes as well. So this was about dizziness. Any questions? Anybody?
Term side effects. Did I hear you say that it was a good idea to remain on the statin to stabilize the plaque in the arteries?
Yeah, so it depends on why you're taking statin. If you're just there for well check and annual checkup and everything, you have no problems. There is no diagnosis of intracranial atherosclerotic disease. You have no history of TIAs or strokes. Yeah, if it's brought in under control, your primary care doctor might lower the dose of that, right? And many patients say, you know what, it's a well-checked thing, annual visit. I'll cut back on my cholesterol intake. I will do regular exercise. They may not even need it. But when patient comes to me from neurology perspective, so the treatment have different guidelines by different specialties, right? So from neurology perspective, from American Stroke Association perspective, if somebody has a risk of stroke or had a TIA or stroke, I keep it on them. And especially if the CT angiogram done and found intracranial atherosclerotic disease, which is usually asymptomatic, you wouldn't even know about it. For Sampras trial, that is the recommendation. I only lower it if somebody says I can't stand it, I have pain in my muscles and stuff. And now the newer Repathas and those are there, they are pretty good too. But some other non-statin medications have not shown as much of robust data for stroke prevention. You know, like ezetimibe and those kind of things, or you know.
I have a question.
Yes.
My son is a drug addict, and there have been many times where he had seizures. Now, when he goes to prison and stuff, you know, they don't give him medication for that. Have you done any studies of how this affects his brain, having all these seizures over these many years? Thank you. I didn't mean to be personal.
No, absolutely. It's a really, really important question, and I had similar situations in the past as well. The mistake where many other neurologists or other general doctors or prison doctors make is they just go by, oh, it's a provoked seizure, it is not epilepsy, you don't need a treatment, which is sometimes not correct. Let's say somebody has alcohol abuse problem or some other drug problem, okay? They can cause seizures. And they fall during the time they hit their head, they got some injuries done. Now there is a new reason to have a continued seizure. Because all of us, every human brain is at potentially can seize. Because it's an electrical organ and anything goes wrong, you are at risk. But everybody has a different threshold at which that brain will seize. If you are already vulnerable to that because of history of drug abuse, because of history of falls, and you have sustained, you know, some injury to the brain during one of those falls, because depending on what drug abuse you have, if it's a cocaine or something, what does it do? It causes vasoconstriction. It causes vasoconstriction, it can cause MI, and it can cause small strokes. If they don't know why this person has strokes, they really can't make a judgment whether this should be treated as an epilepsy or it should be not treated, given that it is a provoked seizure and there is no independent risk for that. So he should get an MRI of the brain, make sure that there is no injury from any of these prior events. And if there is an injury, and he should get a brainwave test done, EEG, to see if there is an abnormal epileptic activity happening, and should be done. And again, let's say you don't even have all those information, but if he's getting seizure, that means his threshold is less. So he should be put on a medication to prevent whatever cause may be, even if it's a drug abuse cause. At least he should not have a seizure. So I would put on a medication like a Topamax that would help cut the desire to use a certain drugs, including alcohol, including smoking and other stuff. And it's a good seizure medication. Okay.
How much of a blockage do you have to have in the carotids before they do something invasive?
Yeah, so again, as I said earlier, if you look at the carotid artery stenosis and the recommendations on that, if it's symptomatic or if it is asymptomatic. If it's symptomatic, anything more than 50% needs to be fixed. Okay. If it's asymptomatic, then usually they say 50 to 69% they still watch, but if it is more than that, that needs to be fixed. That is a overall recommendation, but have I seen people with stroke and their carotid ultrasound shows less than 50% blockage? Yes, I have. Okay, so you have to make a judgment call on those things. But do we just recommend everybody to get it stented or cleaned up even if they have no problems and their blockage is less than 50%? No, we don't. We don't have those resources and stuff to do everything for everybody. So what we do is we come up with these guidelines to see that who absolutely needs it, right? So that's where this whole guideline comes with.
You mentioned the sudden unexplained death from epilepsy. Is there any way, any testing that they could have done or could do to figure out which person was going to have the death from it?
Yeah. Good
I
question.
understand it happens mostly in males between 28 and 35. Is that still correct?
No, it can happen to anybody in any age.
Okay.
Yeah, there are a lot of if you see a Disney star actor who passed away from SUDEP a year or two ago, actor John Travolta's son passed away from SUDEP. There have been other as well, and in my practice I've seen it's not that common, but it does happen. So if you have a patient who gets seizures, convulsive seizures, risk is highest. Seizures from sleep, risk is higher. Even complex partial seizure, that was the old terminology, the new word is focal unaware seizures, there's still some risk. So how do you do? So you check their rhythm, okay? If they are already having cardiac arrhythmias, pauses here and there, make sure that they're not on any medication that does QT prolongations, those kind of things. So if you have a high suspicion, you can get a Holter or a loop recorder to see how well their rhythm is. And I certainly have my top priority for a seizure patient is I make sure that they don't get their convulsive seizures and they don't get their seizures in sleep. Okay, we still work on their daytime seizures because any seizure is not acceptable. But these are the top things that you don't have at death because of these things. And then we have so many new technologies and stuff in the field of epilepsy now. It's not just pills. We can do vagus nerve stimulation that cuts seizures by 50% in 50% of the patients. It also helps with their mood and depression. And if that doesn't work either, we have now FDA approved RNS system, which is only one company, so I can take a name. It's called NeuroPace. What it does is it's a small a pacemaker, a seizure pacemaker kind of thing that sits in the skull, depending on which side the focus is. So we do MRI brain, 3 Tesla, it cuts everything. Brain wave test that we do in Orlando. We have up to 1 week patient comes and stays in my center there. We hook them up, we watch them on the high definition cameras, see what's going on, what kind of seizures do they have. we localize it, and then we characterize it. This is the kind of seizure they have. And then I work with Mayo and Tampa General, where I send my surgical cases. Okay, so we go after it. If it is coming from a non-dominant brain, like right-sided in most people, and if it is an area that is not so eloquent, that does not have language, hand control, something like that, we cut it out. Okay. Do you get this medical magazine called Florida MD in your? Some of you are working, some of you maybe not working. But last year I was featured on the cover story of that. I will share it with you. You can spread that. In which I talked about all the aspects of epilepsy, starting from how we diagnose, what are the usual symptoms, how we treat with medications, and what are the surgical options. So in responsive neurostimulation, we put 4 contacts through electrodes on the spot of the brain, which we cannot cut, but is causing seizures. And that small device sits here and records it non-stop. So patient comes in, and then we put a wand on that, it display the whole brain activity on a tablet. And then we do AI, we train that small device that every time you see this waveform, which we decide that is a seizure, you zap it with a big current there. So within first second or 2, as soon as it detects it, it zaps it and disperses it. So it has a high success of about 72% in reducing or stopping the seizures. And those patients, if we are not able to figure out where exactly to put it, we can do, there's a Santa trial, anterior thalamic nucleus, we put deep electrodes, DBS. So you may have heard about DBS for Parkinson's disease, now it is also for epilepsy.
Sir,
Yes.
are there neurosurgeons in your practice also?
Not in my practice, but I collaborate with neurosurgeons of Tampa General, Mayo, and other places. So I trained my initial fellowship in Cleveland Clinic, which is probably the best epilepsy center in the country. So one of my seniors from that is head of Tampa General, Dr. Rathore. My another senior from Cleveland Clinic is head of University of Florida, Gainesville, Dr. Kalamangalam. And 3 of us actually hold the highest honor in the field of epilepsy called FAES, Fellow of the American Epilepsy Society. 18 doctors in the history of state of Florida, I'm not talking about right now, history of the state has received that honor. And if you have my card, you see that after MD. It is given after at least a decade of your illustrious career and contribution to the field of epilepsy. So I collaborate with them, and Dr. Serwin, he also serves on our Epilepsy Foundation. He's in Mayo. So depending on patient's convenience, if someone here wants to go to Gainesville, it's easier, or prefers to go to Tampa, or prefers to go to Mayo, I coordinate with them.
All right, could you talk a little bit about the etiology of benign essential tremors, whether or not it's vascular in nature or neurodegenerative disorder? Of course, it is something that would be a little bit worse.
Yeah.
Seems to be running rampant in the villages.
I know. Yeah, and let me tell you, share my experience with you. Many of the patients who come with essential tremor diagnosis and saying not getting better. I've been on a bunch of medications, I cut down on my caffeine, I did everything. It's not getting better, now it's actually getting worse. And many of those, not all, but many of those actually had Parkinsonian tremors. So I diagnosed, changed the diagnosis, changed the treatment, now they are doing great. So if you never had an essential tremor earlier in your life, and it's starting after 60, you have to be very careful. And to be honest with you, early in my career, I had made that mistake too. Because it's really difficult to tease out whether it is a essential or whether it is a rhythmic at rest tremor. You may have, now how to differentiate between these two, right? So patient comes to me, say, I had it for a long time, and this is the only problem I have. I have no problems other than that. So I would lean towards possibly essential tremors. These essential tremors are low amplitude, high frequency. So they will be like this, okay? Whereas the Parkinsonian tremors are at rest, and little different. Sometimes there is a combination. Parkinson and tremors sometimes get worse, sometimes gets better. By the time they went to the doctor, it was primarily the essential, they got stamped with essential tremors, treatment not working because of this. Look for other things. Do you have any balance problem? Okay? Is there any asymmetry? Is your right hand more than the left hand? Essential will have symmetric. Parkinson will have one always start first, followed by the other. And they may have a little balance problem. Ask if they have constipation, well, which is a very non-specific, could be from a variety of reasons, but it can precede 10 to 15 years before tremors comes in or stiffness comes in. Ask if their sense of smell is good or not. There can be hyposmia or anosmia in Parkinson's disease. Because Parkinson's disease, most people just say, oh, basal ganglia, dopamine deficiency. It could be actually Parkinson's plus. There may be brain degenerative changes happening. So over here, where your orbital, bulb is there coming from the nasal area, that can get atrophied and you have poor sense of smell. Many times they say, food doesn't taste good so anymore. Because you need to have a good sense of smell to really taste your food.
Okay, ladies, this will be our last question.
Very quick question. What are your thoughts on an ocular migraine?
So as I said earlier, migraine is a weird animal. It can present in different varieties. It can have a basilar one, it can have an ocular one as well.
Right.
It can have a hemiplegic migraine, right? So ocular migraine will give you visual symptoms, basically. It can give you double vision, it can give you blurry vision, okay? Sometimes it affects your vision acuity as well. So yeah, ocular vision treatment is the same. It's injury to the brain, right? And any injury to the brain can cause seizures. Eventually, 4% of them keep having recurrent seizures, which is the definition of epilepsy. But not every seizure is epilepsy. You got one seizure, nothing happened after that, so that was a seizure disorder or seizure event. Some people get seizures from alcohol withdrawal. Some people get a seizure from a reaction to medication, right? Those are not epilepsy. Epilepsy, you've got to have 2 seizures 24 hours apart, unprovoked. So stroke in 4% of the patients can have recurrent seizures. And sometimes not every seizure is convulsions. Most people think that way. Seizure can be as subtle as you are completely with it, you are sitting here and you have a deja vu sensation. And I've seen this before. Okay? It's normal, many times we do feel that way, but if it's recurrent, that is a cause of concern. If you have a weird taste in your mouth, a metallic taste, for no obvious reason, you have a weird sense of smell, a pungent smell with nothing around. Some people have out of context smile, okay? Gelastic seizures. It could be a smile, a smirk on the face, it could be a giggle, it could be a LOL, laugh out loud. A range of it. And these are temporal lobe seizures or the associated areas. Some kids have that, hypothalamic hamartomas. They giggle like anything. I think that's the least or less worse type of seizures. All it causes is some giggling and stuff. But it's a seizure. Okay? And sometimes you may have visual phenomena that you may see shapes and stuff. Somebody was talking to me earlier about hallucinations or seeing things. So seeing things could be a part of dementia or a medication side effects, or it could be a seizure, right? Visual loss could be from that as well. Sudden confusion, sudden dizziness, headache after this episode. So if everything fits that description, sometimes patients just tell me they are there to see me for headaches. So that's called ictal headaches. You can have a seizure and it will give you headaches. Migraines, it's a range, like in autism spectrum disorder, there's a whole spectrum. Migraine is a slow-moving abnormal current of the brain. Seizure is a fast-moving abnormal current of the brain. So sometimes people start with having migraine history for a long time, and then they end up having a big seizure called migralepsy. So there is a transition, there's a range in that thing as well. So yeah, all these things, there are some subtle nuances to it. But as far as dizziness and stroke is concerned, do you have any other questions for me? Or if you want to talk about Parkinson's or MS or anything, I'll be happy to answer the questions.
For a long time, we were told if someone had a seizure to stick a tongue blade or a spoon or something in their mouth to protect them from their tongue blocking their airway. And nowadays, they tell you just to leave the person alone. Is that, why is that?
Yeah. You don't want to put anything in the mouth when the patient is having convulsive seizures. Okay. What is best to do is to put them safe. Okay, they don't fall or hurt themselves, put some a pillow or something, and make sure that if there is secretions, if you have something to have the secretions suctioned out, that you can do, but don't put your fingers or any metallic stuff. They will break. They will chop off your fingers, or their teeth will break with the metallic stuff. Okay, so turning on the side, and we are still working on certain research. Is there a chin lift, tilt, neck tilt is helpful to make them breathe better? Because there is a whole tightness around the whole thing and increased secretions that they feel very suffocated and choked up. And that has a lot of stress on your heart as well. And sometimes arrhythmia happens during the seizure. So seizure is a arrhythmic activity of electrical activity of the brain. It also affects the rhythm of the heart as well. And there is a 1% chance of heart stopping and not starting again. That condition is called SUDEP, sudden unexpected death in epilepsy. So there is always a 1% chance. So the seizure types, if somebody says they get convulsive seizure, the risk is highest for that. If somebody says they get seizures from their sleep, risk is highest for that. So sleep and convulsive seizures are the highest risk for sudden cardiac arrest. So, yeah.
Yes, are you accepting new patients now?
Yes, I do. There may be, let me tell you honestly about my practice, okay? So I'm here one day in Summerfield, which is usually booked up because it's one day a week. Wildwood has a little bit more availability because I'm there 2 days. And if you don't mind traveling all the way to Orlando, I'm just 3 miles north of Universal Studios. So that is my spectrum. And one more thing, please be patient when you come to see me, because many times, when patient comes to me, they bring a bunch of papers, CDs, I give them full time. Sometimes it is little or over the boat. So my patients who are waiting outside, sometimes that's the only complaint my patients have, to be honest with you, that they may have to wait a little longer. And sometimes I'm running behind on those. I'm not the type of doctor who would step in and say hello and everything, take a look at the report of something and walk out. Okay? I look at pictures myself, and many times I have seen things which were not reported. I make my patients understand what that means. I show them pictures, I explain to them. So rest assured, you will get the most educative visit, but if that's happening to the patient before you, you may have to wait a little bit.
I just wanted to clarify.
Evaluation taken in the last 24 hours, you're not a candidate. The first thing you do is see plain CT scan. There should be no bleed on that. And it takes 2.5 hours for the best trained eyes to pick a evolving stroke on a CT scan. So if somebody showed up within an hour, CT scan will be normal. Okay? 2.5 hours before it starts showing up. Next day you will see a hypodensity on the CT scan. Okay? Yeah, so fortunately the place I trained is the birthplace of neuroradiology. The first human brain picture, pneumoencephalogram, was taken at Johns Hopkins. So whenever we had a chance to go to the radiology, it used to say, welcome to the birthplace of neuroradiology. So as a physician, I read what the radiologists say, but I read my own pictures. And you can ask any of my patients who come here, I actually show them. I pull up the image, I explain it to them, because the whole report has a bunch of medical jargons that you don't understand. Microvascular ischemic changes, blah, blah, blah. They have no idea what you're talking about. So it's a part of my practice that I show pictures and explain it to them in simple English. So CT scan, if there is a concern that there is a major clot sitting there, CT angiogram, and we alert the interventional neurology as soon as we suspect that this could be a thrombectomy case. We can give a TPA, okay, and then you can do thrombectomy as well. They are not exclusionary. So those are the things you need to do. And then patient, once they get into TPA, they have to be watched in ICU. Within 24 hours, you have to repeat a head scan, either CT scan or MRI. Make sure there is no bleed. And once there is no bleed, you start aspirin or Plavix or some antibiotics. And then before discharge, they should be on a statin, irrespective of their LDL levels. The recommended level of LDL in a stroke patient is 70 or less. Okay? 70 or less. But I keep it, doesn't matter. If they follow up with me and they have improved, their LDL is now 60, I say stay on it. Why? LDL level is pretty good. And they are general doctors, they may say, you know what? No, there's no need, you're good. Your level goes, no, from stroke perspective, because it is not just LDL lowering, but it is also a clot stabilizing effect. So the clot that is built up, it stabilizes it. So it's hard for it to break and cause an embolic stroke. And it has some neurocognitive anti-inflammatory properties and stuff. So if somebody can tolerate statin, atorvastatin or rosuvastatin, the high potency one, they should be on that. If they are naive to that, you're starting for the first time, start with a low dose 20 milligrams, see how they do. If they're not having aches and pains, for statin myopathy, keep going up and achieve the 80 milligram target. And take it at bedtime because it blocks the HMG-CoA reductase enzyme, which is more active in night. So anybody taking statin in the morning, they are not getting the biggest bang of the month. So they should take it at nighttime. So this was about artery to artery or those kind of strokes. Now there is a whole group called cardioembolic stroke. The emboli that comes, the clot that comes from the heart. Okay? So if somebody has a history of MI, it puts them at risk for stroke. Because the left ventricle, which is pumping, and if it is that side of stroke, it may not be pumping good enough, there may be a pocket of wall motion abnormality. And in blood, that is not flowing at a proper speed, whether slow or fast, tends to block. So always you've got to have an echocardiogram done of your patient, especially with bubble study. So they do the saline, agitate it, and push it from here, and then they see if it's crossing over from right side to left side to rule out patent foraminal well. Because most of the strokes, like a little less than half of the strokes, sometimes you don't find any reason for it. And that is called cryptogenic stroke. And a few years ago, there was a paper that recommended that, closure of TFO is advised. It used to be, no, we don't close it, get rid of it, but that advice has changed. Okay, so somebody has clot in their legs. Let's say you're flying 14 hours or something, like I do when I go to India. So that puts you at risk for clotting. So every now and then, if you're sitting a whole lot, make sure you uncross your legs, move it around, walk a little bit, make sure you're hydrated. If you're dehydrated, you are at risk for clotting in your legs, right? And sometimes you may not have the classic symptoms of, Bowman sign, leg is swollen up and it's hurting. That is really obvious. Sometimes it is tiny wee one that doesn't do a whole lot of problems, but it travels to the right side of the heart, crossover, gets pumped up, causes stroke. So make sure you hydrate yourself and everything that. So for this thing, a proper, complete evaluation regarding a secondary stroke prevention or even a primary stroke prevention. Because if it's happening one every 40 seconds, as you're growing older, the risk is there, especially if you have diabetes, vascular strokes, and family history of strokes, and all those kind of things. So you should get yourself better primary secondary stroke reduction rather than a secondary one when it already happens. And once it happens, the highest risk is in the first week to happen one more time, followed by within first month, followed by within 3 months, and then the risk falls down to the general population. So you have to be really, I have seen patients who came in with stroke, ended up having one more stroke, the stroke alert in the hospital. So those patients do not qualify for thrombectomies or thrombectomy they may, but not for TPA. Because they just it has to be within that 3, 4, 4.5 hours time window where you can give the clot busting medicine. Okay? And these some deficits. either transiently or permanent, that is stroke. Now, stroke can be of different types. The most common, and 87% of the time, is ischemic stroke. That is lack of blood supply to a certain part of the brain, which causes injury to the brain. In 10% of the cases, it could be hemorrhagic stroke. There can be a bleed into the brain that causes injury to the brain tissue. 3% of the time, there can be subarachnoid hemorrhage strokes. And rare cases, as I said earlier, hypoperfusion strokes that I described earlier in the brain's watershed areas. So how common is it? Approximately 795 or close to 800,000 stroke cases in the United States every year. One stroke case every 40 seconds. Every 40 seconds. Okay, so it's very common. The world's GDP, 0.66%, close to 0.7% of the world's GDP, which is $720 billion, is spent on care for stroke. It is the number one cause of disability worldwide. Second most common cause of death worldwide. Fifth most common cause of death in the United States. So US, we are doing much better compared to many other countries, especially who are not so developed countries. It is a second leading cause of death. The cases have gone up maybe because of the diagnostic cases, but overall in last 17 years, it has reduced because of the advanced care we have and all the secondary preventions or primary prevention we can do. So this is the outline of what stroke is or its epidemiology. Okay, what are the risk factors for that? What can you do to prevent it? So in many cases, you can look into prevention. Most of the cases patients comes to me, we are looking for secondary prevention. That means not to let it happen again and try to reduce the risk factors and try to regain as much as we can, the strength-wise. So what are the risk factors? Smoking, a big risk. Okay. Most people think that smoking is COPD or cancer, lung cancer, but it causes increased atherosclerotic disease. The nicotine goes and attaches to the intima of the blood vessel, creates an inflammation. Atherosclerotic process is more there. It causes blockages in your carotid arteries, in your coronary arteries, in your cerebral arteries, in your leg arteries. Okay, so it can cause claudication, like blockage in the leg. So they walk, and after walking a little bit, the leg starts hurting. You have to sit down. Coronary arteries, entire different topic, but it can cause as well heart attacks. And in the plaques, in the carotids, some of those plaques are not fully calcified, so they are called soft and unstable plaques. So they can break loose, go up, get stuck, cause a stroke. So smoking, earlier, few decades ago, it was considered really, really normal. So many people were smoking. But these days, thankfully, there is more awareness and people are not smoking that much. So if you see somebody, there is one thing you want to tell them that's going to improve their quality of life and their life expectancy is to quit smoking. So I do that counseling for every patient I see, and I really tell them the reality, the facts, even if it scares them. Okay, sometimes it needs a little bit of that fact check before they realize it, because many of the patients who come to me, they say, "Doc, I quit smoking after my stroke," and they are already paralyzed and stuff. How good that would be, you know? There's a 50% mortality after a major stroke in many of the studies, 50%. Very lucky people will get a warning of a TIA, transient ischemic attack, which is stroke-like symptoms which resolves quickly. Okay? The only difference between a TIA and stroke, it's not resolution of symptoms. You may have a tiny stroke and symptoms resolve. It is the absence of stroke, visible stroke on MRI. Somebody had a symptom of stroke, all the facial arm weakness, leg weakness, slurred speech, not able to speak. It got better and then resolved within an hour, within 24 hours. You say, oh, it looks like TIA. No, until you have an MRI done and that MRI does not show any stroke, it could be, then only you can say that it's a TIA. Or it could be a stroke if you see that on the MRI. Okay? There is a whole class of thing called MRI negative strokes, which can be in 10% of the cases, especially in the brainstem areas and stuff, because the regular MRI that is done is a 5 millimeter cut. So the two images are 5 millimeters apart. If there is a tiny stroke in between those two, people are scratching their head, they say, it looks like a stroke, patient has a little bit of weakness here and there. MRI came back negative. Even many physicians who are not aware of this thing, they say, oh, okay, I don't know what it is then, right? So if you see that, and especially if it's a posterior fossa thing, CT scans are notoriously bad to miss that. So CT scan is not good for posterior fossa strokes or the brainstem stroke. So you have to have that clinical suspicion that, you know what, no, clinical exam history highly suggestive that this is a stroke. I'm gonna ask MRI to do it again with thinner cuts, 1 millimeter cuts. So you order that again saying, earlier was not able to catch it, I have high suspicion, please repeat it with 1 millimeter cut, especially in the brainstem. And then you see that. But this is an interesting phenomenon, MRI negative strokes. So, what are other causes? Diabetes, again, that causes atherosclerotic disease. Hyperlipidemia, also another cause for atherosclerotic disease. And carotid artery disease, intracranial artery disease. If you see carotid artery disease, okay, this is a whole different topic then. If they have symptomatic, then more than 50% blockage, you should go to clean it up. Whether you do carotid endarterectomy, better for elderly patients, stenting for younger patients. With stenting, there's a little higher risk of MIs, even if it's a small one. For carotid endarterectomy, there's a little higher risk of stroke, tiny bitty strokes. When they go in, clean the junk up here, some of it flies up, causes a mild stroke. So now they have an umbrella device that they do that to protect from that thing. So anytime somebody is getting carotid endarterectomy, make sure that they are using the newest technique of umbrella device. Don't go by somebody, you know, somebody who's not using it, has been using the conventional way of things. So I see patients post-carotid endarterectomy strokes, they come to me. So these are the things that you should be aware of. If anybody is going for it, then they should definitely, this procedure requires mandatory neurology clearance. So, you know, that's a good thing that we can alert them that, hey, this is where you should get it done. But it is done by not neurologists, they are done by surgeons and vascular surgeons. So this is one of the reasons for having strokes. You should check if the big pipe here is a major cause, right? For unilateral strokes, that happens. This junk builds up over a period of time, gets loose, goes up, causes stroke. The other one is, it could be inside the skull as well. The artery is inside the head, right? But according to Sampras trial, they looked at it that these should not be stented or opened up. Maximum medical management for Sampras trial is recommended for atherosclerotic disease inside the head, okay? For neck, you clean it up. Inside the head, max medical. Now, what is max medical management? Dual antiplatelet therapies, aspirin, Plavix, right? Lifelong. High potency, high dose of a statin. High potency, which are the high potency one? Only two, rosuvastatin and atorvastatin, not Simvas, not others. These are the high potency. 80 milligram of atorvastatin would be the right answer for that. Okay, sugar control as best as possible. Blood pressure control. We say blood pressure, okay, 120/80, perfect, right? If you look at the curves at which the stroke risk starts going up, is around 115 systolic. But don't have to freak out that, hey, 120 is bad, no. But that's when the curve starts going up, and as the blood pressure goes up, it keeps rising up. So somebody with 140, yeah, I mean, you have to reduce that risk. 160, 170, oh, it's a ticking bomb, right? So blood pressure, sugar, cholesterol, no smoking, regular exercise. When you do regular exercise, what happens? I mean, apart from all the health benefits that you talk about, you create a good circulation by tiny vasogenesis, okay? It creates a sense of little less blood circulation. So it creates demand for that. So you're not dependent on the main trunks of your blood vessels, whether it is your left and right coronary arteries or your major middle, anterior, posterior cerebral arteries. There are tiny rootlets, so to speak. They are created if you do regular exercise. So many times, even if the main trunk of one of the arteries gets blocked, there are other tributaries that will either reduce the size of the heart attack or a stroke, or will totally prevent it. Those who don't have those tiny rootlets or a good network of collateral circulation, the technical term is collateral circulation, they end up with a massive cardiac arrest, cardiac MI, or a massive stroke. So not everybody gets warning of TIAs and stuff. Sometimes it is major stroke, and that can be life-threatening. So how to react, the care, the immediate care or the stat care for stroke. So you must have heard about the be fast, right? So the face, arm, speech, and time. Time is brain. You must have heard this 1,000 times, right? Time is brain. Why? Because you lose 1.9 million neurons per minute. An average human has 86 billion neurons, all of us, right? But in stroke, you lose approximately, if you round it up, 2 million neurons per minute. So you don't sit on that. You call 911, you'll get checked out, even if you're not so sure. The first reaction, human reaction, we all have it, maybe something else. It will get better. Okay? So awareness about the seriousness of that thing. If you feel you have a slurred speech, if you feel your face is droopy, if you feel your hand strength is not good, or you're stumbling, you're not able to walk okay, rush to the ER. So you come to the ER, and from a healthcare provider perspective, we have to make sure that are they eligible for a TPA, which could be Altiplace or Tenectiplace. Tenectiplace is a new one, if you want to know about new. Not every place is using it. It is 14 times more potent and specific, not potent, more specific for the fibrin, which we need to break the clot. Okay, and it has a longer T-half. It's a genetically modified thing. So one bolus is good enough compared to Altiplace, where you have to give 10% bolus and 90% is given by a slow infusion over 1 hour. Although both are found to be effective. Approximately 5 to 6% case of bleed can happen, so you have to make sure you talk to the patient and the family. But look at from the other angle, 94% chance that they're going to do well, right? So those who are candidate should get that. And those in the scans we see a major clot sitting in one of the major arteries, then a thrombectomy to go in and take it out, that would be life-changing. So I have seen patients with best timings. They just had things, they called in, they are brought in, and the team was already ready, and we did everything as the best possible, but still patient did not do well because they did not have collaterals. They were dependent on their major arteries. And I have seen patients in my practice where it was not the best timings. I hold the record for Lakeland Regional Health of the best timings for the stroke TPA given. Okay, so because my residency program did not have a stroke fellowship at the University of Illinois at Chicago, so as a resident, we were trained to do that thing. Okay, I don't do that anymore. I felt burnt out with that. So now I do. Yes, please.
Did TPA give
Is dehydration also a cause of dizziness, light dizziness?
Yes. As I said earlier, hypovolemia, if your blood in the arteries is not that great, and if you check, and that will be manifested as most likely you're okay when you're laying flat. As soon as you stand up, you feel lightheaded. Okay? And your diastolic blood pressure is on the lower side. Right? And the other thing that many times people think, when I ask them, do you drink enough? They say, yeah, I drink enough. Right? People usually drink when they're thirsty. That is the cry for water from their body. It's an extreme response when you're really dehydrated. So I tell them, no, okay, watch your color of your pee. What color is it? It should be clean. If it's yellow, you're a little bit dehydrated. If it's a dark yellow, you are severely dehydrated. On top of that, there are a bunch of medications. They have their side effects of dry mouth and other stuff. That worsens it. And there are certain medications which has effects on relaxing your arterial walls. That drops the pressure too. Then there are certain medications like diuretics, whether it is a new diuretic like furosemide or whether it is a milder one like hydrochlorothiazides, which are used as blood pressure control. Sometimes they overshoot and drops your pressure. So low blood pressure, which reduces the cerebral perfusion and can cause one type of stroke. So the central part of the brain, right here, is the watershed area of the brain, which is at mercy of the main arteries or rivers, so to speak, if you want to say that, because all of these sides are supplied by your middle cerebral arteries, posterior cerebral arteries, anterior cerebral arteries, but in the center is at the confluence of small creeks of these major tributaries. So if you drop your pressure, this is the area to suffer the most. So one of the strokes, you may have heard about stroke, ischemic strokes, hemorrhagic strokes and stuff. This is hypoperfusion stroke. And this is the area when it goes, it affects your hand areas and over here. So you basically have weakness around the trunk and these kind of things. All right? So this hypovolemia is not just minor dizzy episodes. You can pass out, you can get hurt, you can have a hypovolemic low perfusion strokes. So it is really concerned. So what I tell all my patients is, take a big pitcher, this big, okay? Put in some lemons or some cucumbers, make it nice and flavor if you don't really like a taste of bland water. Put it in the center of your living room where you walk around, do your chores and stuff. Every now and then take a sip. By the end of the day, a couple of hours before you go to bed, make sure you finish it. And keep an eye on the color of your pee. Don't wait until you get really thirsty. Okay? If you do that, you're ensuring that your blood volume is good, you're hydrating, and hydration is such a underappreciated in many of the health aspects of it. You cleanse your body if your hydration is good. So make sure, and then don't overdo it, because then you might drop your sodium causing hyponatremia, dilution of hyponatremia and stuff. So a big pitcher with 5 to 8 glasses of water, 200 cc's each or something, make it a nice flavor or something, and if you like iced tea, anything else, okay? No sugars or anything. Make sure you're hydrating yourself. Every now and then, keep an eye on your blood pressure if you really have concerns about low blood pressure, especially when laying flat, standing up, watching mostly your diastolic blood pressure. So long answer to your question.
Okay, I'm coming.
Here you go.
Can you explain the difference between dizziness and giddiness?
Giddiness is mostly when nausea is associated with that. When you feel nauseous, you want to throw up. That is giddiness. Dizziness, I said, it's a very non-specific. It could be many of those reasons that we just talked about.
It doesn't have anything to do with the balance.
Yeah.
What is giddiness rather than
Giddiness is mostly if you feel nauseated with that, not necessarily if you are unbalanced. An unbalanced thing is, as I said, if it's a vertigo, you will not be able to balance yourself because all signals are sent to your brain and brain gets confused and then everything is moving around. Or if there is a cervical spinal stenosis, your leg sensors, nerves, the proprioception, which sends signals, it gets compromised here, so your brain doesn't know how to balance you. So those who have balance problems because of the cervical spinal stenosis, they should watch the floor when they're walking. Every now and then when you're walking, you keep an eye on your feet and then make that connection further down there, and then you watch it when you're walking. You will see a dramatic change right away. Because now you're not dependent on the nerves of your leg, which is coming from the spinal cord, but your vision is going to tell the brain how to balance yourself. So when I walk my patient and I tell them this simple trick, there's an instant improvement. So, yeah. All right, should we move to stroke? Yes.
one more?
Are you using Botox for migraine headaches?
We do. Yes. So Botox used to be very popular before because of certain limitations in the medication options. But lately, in the last few years, there is a new class of medication called anti-CGRPs, an calcitonin gene related peptide. That is a revolutionary medication for migraines, okay? We have a huge success with that. It comes in pills as well as once a month under the skin subcutaneous injection. One of them is also quarterly under the skin injection. So they have reduced the need for doing Botox that often. But some patients may have what we call as compound headache syndrome, which is not only migraine, not just cervical, cervicogenic headaches or tension headaches. They may have a combination of those things. So in those cases, we do Botox, and I'm certified to do that, and I do that actually.